Welcome to PharmacyToDose, the critical care podcast, where we're discussing critical care and its pharmacotherapy in a fun and entertaining manner. Each episode, we summarize the available evidence, discuss controversial issues, and provide practical take-home points with a subject matter expert. And I'm your host, Nick Peters. Wherever you are and however you are listening, thank you. Now, a quick word from our sponsor before we get started today. QXMD builds mobile solutions that drive evidence-based care in clinical practice. So check out Read for easy access to research personalized for you, Calculate for over 500 easy-to-use decision support tools, and Learn to earn CME online in minutes per day. Try them today at qxmd.com/apps. Again, that is qxmd.com/apps. I think everyone has had their lives turned upside down, either personally, professionally, or both over the last few days to weeks due to the COVID-19 coronavirus. And normally, I'd like to talk about some upcoming things, things we have in the pipeline kind of in the beginning of the episode, but I'm going to kind of save some commentary and things for after our interview, because we are joined today by a special guest and a friend of the pod, Andrew Barnes, talking about his experience with COVID-19. Now, Andrew Barnes is the current director of the PGY2 Critical Care Residency at the University of Washington. He received his PharmD from the University of Washington and also completed a PGY2 in critical care at the Medical University of South Carolina, MUSC. His current practice location within the University of Washington is in the oncology bone marrow transplant ICU, and he is taking time out of his probably chaotic schedule to talk to all of us about his kind of personal experience with everything that's happening with this. So, Andrew, thanks so much for joining us today. How are you?
Doing okay so far. Now, just trying to survive our. Oh, go ahead.
No. I was gonna say, how long have you lived in Seattle?
So I am born and raised. In fact, I ended up buying a house probably like 6 blocks from where I grew up. But went to school at University of Washington. Then the first real trip out of the state was when I did my PGY2 in Charleston. After that, I moved quickly out of the Southeast and back to the Northwest. And I worked in Portland, Oregon for a couple of years at a private hospital down there, Good Samaritan, before coming back to the University of Washington. I did cardiothoracic surgery for many years on our department. And then, so I'm 51 here, so pretty much most of my life.
Have you ever seen the roads or city this empty?
Well, to be honest, it's kind of crazy because Seattle, back when I remember it, way back in the day, wasn't very busy before we had Boeing and Microsoft and then Amazon. And so now normally traffic is gridlocked. But now even with the little bridge that I used to get out of town shut down, which happened last night, it's a little bit more traffic, but I think that's probably because there's limited ways for me to get from where I live to work. But on the main roads itself, everything is shut down. The governor last night pretty much issued a stay-at-home proclamation that starts tomorrow for most services.
And so the stay-at-home kind of proclamation is kind of on top of everything else that they've been doing in the city, right? With the schools closing, right, limiting gathering, and all those types of things. So,
yeah. Pretty much everything is shut down. You can they have a pretty long list of essential services, obviously healthcare, pharmacies, grocery. Kind of actually surprised me how much longer that they left the list. The medical cannabis was left on the list as an essential service, which is a very Seattle thing to do, I imagine. It's all the restaurants. If they can do takeout, you can get food from a restaurant. But other than that, you're pretty much supposed to stay home.
What are you doing to kind of help to kind of cope with the quarantine or social distancing?
To be honest, I am a little bit of a recluse to begin with. And so my wife and I, though, our big thing was always sporting events. So we have season tickets for the Sounders, our soccer team here in Seattle, and the Seahawks and the Mariners. We do a lot of games on the Mariners. And so not having sports is kind of like our big thing that was our social thing in the past. And so without it, it's just me and her just kind of hanging out watching TV. So it's watching Netflix reruns of different shows.
I don't know if you'll get there, but I'm at the point now where I'm streaming old sports games on YouTube to give a little bit of a fix.
I'm almost there. I am definitely almost there.
So to kind of give everyone some baseline perspective, just generally speaking in the University of Washington, like what's the ICU like in a typical flu season? Is it pretty busy, kind of filled with some pretty sick patients?
Yeah, it varies. We have 3 hospitals in our system. There's Harborview Medical Center is our county hospital, and it's run by the University of Washington for the county, though. And so they have a lot of, underserved populations. And so the flu season usually hits them pretty hard. It also hits my unit really hard. Any respiratory virus in a neutropenic patient obviously is trouble. And so respiratory virus system always slams us pretty hard. Our other units, our hospital is kind of all team based. So pharmacists are based on a team rather than a specific unit itself. And so, CT ICU, CCU doesn't see a ton of that, but the medical ICU, onc ICU sees a fair amount of flu and other respiratory viruses.
Now, the first COVID-19 cases were diagnosed in Seattle in kind of late January. When did you start to notice maybe like an uptick of patients, being admitted to the hospital and to the ICU with those kind of symptoms? Was it around that time?
So I can't speak to our other hospitals because one of the things that they elected to do was put most of the initial patients at our hospital, University of Washington Northwest, which is a community hospital that they acquired, but it's mostly hospitalist based. And so there's fewer, residents and fellows and things like that. So it's fewer people that are taking care of the patients. And so we put most of them up there first. We started seeing an influx of some more critically care ones I would say probably a week and a half ago. So patients who required, for example, ECMO, they can't do that at Northwest Hospital. And yeah.
Does that also mean that the hospitals that they were initially going to may be full, or is that more a sense of they needed more critical care that they can't provide at those type of hospitals?
Exactly, and that's what we were seeing initially. We're starting to see more patients up on the floor who are getting diagnosed that aren't as critically ill. But I will say that this thing can move scary fast. People can go from 2 liters nasal cannula to prone, paralyzed, 100% and 18 a peep in hours. And so that's the scary part of this one.
One of the biggest issues I think that all of us are hearing and are acutely aware of is actually testing. So how are you all kind of running the tests? Are they sent out? Are they done on site? And I'm asking because I think Seattle was really at the forefront of doing a lot of this testing when, nationally speaking, we weren't doing as much.
Absolutely. No, I think we have an amazing virology lab, and they were ready to roll instantly. And they're processing upwards of, I think they're at 1,000 tests plus a day capability now, and they have capability to do more is what I heard. So I think, and that's a credit to just our virology lab here is just an amazing group. We've been doing PCRs for a long time for respiratory viruses, and they were ready to roll as soon as they knew what to do.
Now, in terms of the process, do you have to send like a confirmatory test or anything, or is it able to be just kind of one test per patient?
Initially, it's one test per patient. Now, they are testing for 2 specific genetic sequences. I can't remember the ones, but if one's positive and one's negative, they'll send a confirmatory one to the CDC. If they're both positive, we call them positives. Now,
Okay.
we'll wait a couple more days and, if the symptoms subside and they're looking okay, we'll retest. But otherwise, we consider them positive if that first test is positive. And if the test is what we call inconclusive, if one of the genes was positive and one was negative, they'll still keep them on precautions as a rule out COVID and send it off to the CDC.
So kind of building on what you hinted a little bit earlier about how quickly and acutely these patients can decompensate, have you noticed any symptoms other than primary respiratory that patients are coming in or complaining of?
I haven't, to be honest. Almost all of the ones that we've seen admitted are presenting with respiratory symptoms. Now, I have heard tales in the literature now of gastrointestinal symptoms being a potential as well with this virus, but I don't have any direct experience with any patients that came in with that.
Yeah, it would seem that, based on those SCCM guidelines, that most of the ICU patients are, presenting with, though similarly to like severe ARDS and things like that. But I thought it was interesting, that report talking about, anywhere from 30 to 40% of people presenting with GI symptoms, which I think is something that, I didn't necessarily think of with all of this. I thought it was primarily, think droplet airborne. I was thinking, pure respiratory.
Yeah, absolutely. The classic is myalgias, fever, and dry cough. But now we're hearing about this respiratory stuff or the gastrointestinal things, and it kind of makes me wonder how many are we missing that are out in the community already that, I have a little diarrhea or a little gastrointestinal pain, and we're missing them. And that's why I think the testing thing is the key, and being able to run a large number of tests on a lot of different patients, and the fluidity with which this thing is moving. I mean, we're learning things, sometimes hourly on how to manage these patients and how to, assess them. And so that's kind of the scary thing about it, to be honest.
Yeah, we just don't know what's going to happen. And that's what, I'm having to, I feel like, constantly reiterate to people is like, all we're doing is using the data that we have to predict what's going to happen. But at the end of the day, we don't really know, unfortunately. It's all based on testing and controlling, what we can.
Exactly.
Now, what I've been reading and kind of been hearing is that, obviously the risk of hospitalization or becoming critically ill is higher in two specific kind of subgroups. Those who are adults who are 60 and older with some specific comorbidities like, diabetes, cardiac history, immunosuppression, with the risk being even higher in those who are 80 or above. Now, is that in line with the patient populations that you've seen and have been treating, or are you seeing something different?
Being kind of the referral center for the more critically ill patients, we're kind of seeing we've seen more of the immunosuppressed, more of the elderly with severe comorbidities. It's run the gamut, though. I mean, you can have like an 80-year-old who's, they're just kind of camped out on a couple liters and do fine. But then you see somebody who's 50 who we don't know of any comorbidities and they end up on ECMO. And so this thing is just all over the place, to be honest, I think, with how it can present in some patients.
And I think it's the CDC data who reported it. It's coming out that in the United States, the young are being more affected than is what is happening internationally. And I use the word young kind of, I'm including patients who are just younger than 60 in that category. But I think it's important to note that while a lot of those elderly and those above 80 are getting a lot of the concern, right? Someone walking around, you don't know if they're immunosuppressed, right? You don't know what's happening,
right,
or in those types of things. And that's the scary thing.
Yeah, absolutely. And that's why I think the whole message to, stay social distancing, stay away, and I'm standing on the corner waiting for the light to change. I'm making sure I'm like 6 feet away from anybody else, because you don't know who might have it, and and who's going to really suffer from it if they get it. So
So just generally speaking, what's it like kind of being in the hospital right now with it kind of exploding? You hear the term Seattle's kind of turned into one of the hot spots. What's it like?
It's very eerie. It's eerily quiet, and it feels like the calm before the storm. We banned pretty much all visitors. Patients who are imminently dying can have a couple of visitors. People who need like a ride home or something can have a visitor, and they're all screened at the doors. We only allow entrance through a couple of doors, and there's police at the doors, like not just our security guards. It's like the real popo. So it's a little surreal in the hospital because the hallways are pretty much empty except for staff. We've stopped pretty much all elective procedures except for some that would be considered essential, and all in-person clinic visits except for things that would be considered essential. And so it's really quiet and it's really strange.
I think all of us are going to remember kind of February and March as the kind of toilet paper months, right? All the supplies are running low. Everyone's hoarding things. Have you, I went to the grocery store, just yesterday to try to pick up things, and boy, those shelves were bare. And so, have you seen this also from the hospital side of things, whether it's medications, machines, or supplies? Do you feel like they're running lower, kind of like the comparison of what the grocery stores are like right now?
Definitely. The PPE is the biggest thing. The personal protective equipment is running scarce. We're doing so many things to limit the use of it right now. The big concern is going to be the ventilators if we really get slammed with this. Right now we're doing okay. We have bed space. We've converted several like kind of rooms to HVAC, negative pressure HVAC rooms. But the PPE and the concern about if we really see a big influx of patients in severe respiratory distress, that's really what's going to hurt.
Now, for those who may be less familiar, what PPE are like the interdisciplinary team members who are interacting with those patients? What are they wearing? Like, what does that consist of?
So currently we're using for patients who are not getting aerosolizing procedures, so not getting like a bronchoscopy or getting nebs or things like that, we're using droplet contact precautions. And so basically that's a mask with a face shield, gown and gloves, and for the airborne, we're using N95s, what we have left. Otherwise, we're using regular masks right now. The biggest thing that we're doing is limiting the number of people that go into the rooms. For a known positive patient, it's strictly limited. And we have protocols for our code blue and things like that, on how to limit the number of personnel in a room or something like that.
Yeah. How has that affected kind of from a pharmacy perspective? Because I think a lot of times if there's a code, right, we try to be in there. If RSI is happening in front, like we're going to try to be there and helping. Is it changed in the sense of now they're probably still helping, but just more outside of the room, or what? How has that process kind of changed?
So our policy now is that the pharmacist and a lot of the team stay outside the room. The code cart stays outside the room. The defibrillator gets passed in. The pharmacist will get, because I know every hospital is a little different how their pharmacists respond to codes, but our pharmacists pretty much run the code cart for a lot of like not only the drugs but a lot of the equipment too. And so we have these big gallon jug plastic bags that we bring with us to our code, and we have an auxiliary code box in case we need to mix something or need extra supplies. So anyway, we get these gallon plastic bags out of our auxiliary code box, loaded up with things that they need initially, and pass it in. But yeah, staying outside the room, pretty much the entire code now, which is definitely different.
And you mentioned the shortage of PPE, and everywhere you look, I mean, you basically see doctors and healthcare professionals like basically begging to try to get more supplies. So what all have you done to try to help save, or I guess you'd say maybe more ration some of this PPE that you have in stock?
Yeah, one of the things that we did, you know, we are obviously limiting the number of people that go in the room helps with that. We did our compounding pharmacy division at the university is compounding their own sterile hand sanitizer. Don't ask me what the recipe is. I haven't learned it yet, but I want to learn. But yeah, so we're compounding our own hand sanitizer at this point. I don't think they've gone to reusing masks yet, but I know that we've talked about it. We are reusing the PAPR hoods, the personal airway respiratory protectors. They are reusing those, and generally the nurse is kind of the primary person in the room using it. So,
making your own hand sanitizer sounds like we're going back to pharmacy lab where we made like chapstick and things, right? Like the lotions and all that.
I know, and I would be lost.
Yes. If you put us in that environment, I don't think anyone would be convinced that I was a pharmacist if I tried to go back into the compounding world.
Exactly.
Now, another idea I've seen to really help ration some of this PPE is trying to cut down the amount of times that a nurse enters the room with kind of some unique strategies I've seen. Are you all kind of doing anything like that?
Yeah, absolutely. Basically, they're staying in there. We have wireless phones that they carry so they can communicate what they need. Definitely trying to limit the number of people on rounds. Usually one provider will go into the room to do the patient assessment. Just strictly limiting the number of exposures and the number of times that we have to use our PPE.
Yeah. Are these like COVID-19 patients, whether suspected or confirmed, are they in like a specialized kind of closed unit, or are they more kind of scattered throughout the hospital in the various negative pressure rooms?
So the stable patients that are up on the floor, kind of scattered all over the place, that have turned positive. All our hospital is single rooms. Some are negative pressure, some are not. One of the things that we did though for the sicker patients and for patients who looked like their trajectory was going to make them sicker, we converted our surgical intensive care unit is basically our COVID-19 unit now, and the SICU team is taking care of those patients. And they retrofitted some rooms. They took windows out, basically put a big plastic sheet up over the window and hooked an HVAC thing up to it that sucks the air out and blows it outside. And so they did that with a bunch of the rooms up in that unit. Kind of an interesting model, but it's kind of scary too. So we did that with some of the units, some of the rooms on the cardiac critical care unit today. I saw the construction guys up there hooking all this stuff up. So we have a specialized, so we have one specialized unit, but anticipating the need that we might need more than just what they can provide.
It sounds like from what you've described, one of the big things is kind of limiting some of that face-to-face interactions, especially with, patients who may be waiting, their test may be pending or things like that. So that probably leads more to pharmacists being less decentralized, potentially, and maybe more centralized. But what all have you done to help ensure that patient care is still happening while you're kind of trying to keep everyone safe?
So we haven't pulled the pharmacists off the teams. Our pharmacists are all team-based rather than specifically area-based. And so, for example, my team, I round with an attending, a critical care fellow, and generally a nurse practitioner or a PA. We don't take junior level residents at this point, but so it's a small team. So we still round, we still provide care with the patients, but we maintain our social distance, and generally only one person will go in the room if it's a suspected positive. We have on some of the services that cover maybe more floor patients, like the general cards on the floor or cardiac surge patients getting ready to discharge. We used to do all the discharge teaching, in the room, hands-on with the patient. Uh, we're not doing that anymore. We're doing it from either the phone or having the nurse do it, or doing it from the doorway in unusual circumstances. And that's for all patients. That's not just for presumed or waiting for confirmation kind of patients. We use, obviously, being the University of Washington, we have a lot of pharmacy students. All pharmacy students on rotation are now working from home. And so they're working up their patients from home. They're calling their preceptor at a designated time to kind of go through their patients and recommendations. We're having them sometimes call the patients on the phone to do med reconciliation and things like that pharmacy students do. So a lot of changes to the way we practice in general. So.
Yeah, and I like that the pharmacists are still on the teams. I've seen on Twitter kind of the arguments, for pulling some of the pharmacists away versus keeping them rounding. I can see both sides of things, but when you fight to be a member of the team and to be a valued member, when something like this happens, it kind of feels like it should be all hands on deck. But I see the other side of, you don't want everyone falling. So I see both sides of it. But my personal preference is kind of what you all are doing and handling it now.
Yeah, I think, we're really lucky at UW Medicine to have a very collegial relationship with our physicians and our other providers. And I don't think they'd let me get away with not rounding. So.
Now you mentioned how creative you've gotten with the student learners and things on rotations, but how has this affected pharmacy residency? Because you're an RPD. I'm sure it's not business as usual currently, just with everything happening.
With the residents, honestly, we try to let them be as independent as possible. So, for example, I have a resident on service with me. I'm not rounding. I'm staying in my office looking at the patients from a distance, but she's the one on rounds, being the face of pharmacy for the team. And then we meet afterwards. So we're trying to keep the residents as essential providers as well, because we really rely on them for a lot of service in the hospital. And, they obviously have their preceptors that's looking over their shoulder and helping out and making sure they're not missing anything. But at the same time, we want them to get this experience too.
Now, are most of these patients who end up coming in with these COVID-19 symptoms, are a lot of these going to the ICU, or are they going to the general ward? Is it a mix? Like, if you had to guesstimate, what would you say kind of the split would be?
I would say it's a mix. I think we've probably, when I left today, I was trying to think, we had about 6 patients in our COVID-19 unit, like ICU unit. 4 of which were very severely ill. 1 of which was on ECMO. The rest, I would say there's probably a scattered handful, maybe 15 or 20 throughout the hospital in the various wards. So it really hasn't hit the unit as hard as I'm expecting it to in the coming weeks.
Yeah, I saw an analogy that I thought kind of really stands clear. Is it's like, when you have the tsunami wave, when the water gets pulled up, there's a lot of bare sand before it crashes down. And it kind of feels like a lot of us are standing on the beach right now. And this kind of, this wave is just, it's getting incrementally closer to us. Cause you're right. When you mentioned that it's eerie, that was something that I've heard from other people, is the census is actually in some areas down a little bit, kind of preparing for all of this.
Absolutely. With the cutout of the elective procedures and everything, we have open beds in a lot of our units, and it's we want to kind of keep them that way until we really need them, I guess.
Now, we'll kind of focus on the critical care kind of management or the patients here. And so when these patients, present to the ICU, just kind of generally speaking, what is the typical critical care management? I mean, is it really just kind of like with severe ARDS, like all of those same principles, or are you doing anything else in regards to these patients other than kind of supportive care?
I think it's primarily supportive care. I think the realization of how rapidly this can go south, though, is leading to maybe earlier intubations, earlier proning and paralytics if needed. And definitely ultra low tidal volumes is what I've seen a lot of these patients getting. So I think just, again, severe ARDS, supportive care, and then, obviously some of the trial things that we're using.
And and this will be in the kind of the reference list for everybody, but SCCM, the Surviving Sepsis Campaign, came out with some COVID-19 guidelines, and when you look at kind of the summary of the recommendations, for the most part, it's very in line with what we're doing with a lot of those severe ARDS patients. Kind of definitely limiting fluids as much as you can, fluid concentrating, and some of those things.
Yeah, absolutely. Early use of pressors potentially to use more of a fluid-sparing approach is definitely something we've seen.
Are you using a fair amount of corticosteroids on this patient? I know that's kind of I don't know if controversial is the right word, but
yeah. We are not. We are not. I haven't yet to see a patient get corticosteroids. I've had some colleagues who've used tocilizumab, the IL-6 blocker, with the understanding that some of the forms that this can take is a severe cytokine release syndrome. And we have seen elevated we check interleukin-6 levels in a lot of these patients, and we have seen IL-6 levels get elevated. But the feeling is that corticosteroids would probably make this worse and would definitely lead them to have a longer course of the disease. And this is something that we know of in my population, in the bone marrow transplant population. When we have to use corticosteroids in patients with viral illnesses, it's just a huge problem because they're going to get sicker.
Have you seen, I think the other big treatments are, there was the extremely flawed paper kind of talking about azithromycin and hydroxychloroquine. Are you seeing any type of, you have all these other types of treatments. Have you really seen any of those used, or has it really just been focusing on, lung protective ventilation and those types of things?
No, we are using hydroxychloroquine in our patients now. I can't say that I've seen a lot of azithromycin. I think most of the focus has been on the hydroxychloroquine. And then most of the severe patients also, we get them into the remdesivir trial.
That's what I was going to ask that. Yeah. Have you requested have you had to go through the compassionate use process for remdesivir? Although they just completely changed all of that now, and I think you're enrolling in a study. But did you have to go through that? It's an actual
study now. Yeah, the first patient or two that we had, I think, we're on compassionate use, but now it's an actual trial. And we have a big investigational drug service that's working with that at all of our hospitals. That's enrolling the more severe patients on that trial.
So have you, in using, and we'll kind of focus on the two treatments that you talked about, the remdesivir and kind of the hydroxychloroquine, have you seen any type of adverse effects or things that, the listeners and things should keep an eye out for when using some of these meds?
Well, I personally have not. And, the hydroxychloroquine has been pretty well tolerated, even in our less symptomatic patients. It's hard to sort out right now, too, with the remdesivir, because you do see LFT abnormalities with it, but that may be also due to the coronavirus. And so it's hard to sort it out until we really get the data for it. And so, our ID guys are recommending hydroxychloroquine and then pushing people into the remdesivir trial for the really critically ill.
So I imagine most of these patients are being, at least initially, kind of covered for bacterial pneumonia. Have you seen any type of co-infections in any of these patients, either viral or bacterial?
No, not specifically, but we've had a couple of patients, one that was initially a flu A that ended up coming down with COVID. And the other one, you just treat them like you would any other ICU patient. If, they're on supportive care for their ARDS, then they start spiking more fevers and looking more cytokine, then treat them with antibiotics. Because it's hard to sort out when you get the imaging on these guys. I mean, they have, ground glass opacities everywhere on their x-rays, and their CTs, and it's really hard to sort out, like, oh, could this be a bacterial pneumonia hiding in there? And it certainly could be.
From the photos of CTs I've seen, it passes what I like to call the pharmacist litmus test, which means if I'm looking at a radiographic image and know something is wrong, something is definitely wrong, and that's
I agree. I've used that. I've used that analogy all the time with my residents. I'm like, okay, look at this. Can you tell us something's wrong? Okay, yeah. Then it's probably really bad.
Now, one of the, University of Washington has been absolutely incredible with not only some of their research and some of their, like you mentioned, the testing, but also making these resources publicly available. They have a website that is a shared live document that's always being updated, but you all have like your treatment protocols and things listed, which is, we'll have this link for everyone to go visit, but it's absolutely a treasure trove of resources. And I bring that up because under the treatment, they have a general treatment protocol there. Would you say that it's, at this point, most things are happening on a patient-specific decision, or is it more kind of just based on the number of patients you've seen that now it's more of like an algorithm type of approach?
I would say it's still more patient specific at this point. If we really get slammed where, we have so many, it might have to go to more algorithm based, but I think everybody is kind of treating everybody individually. Decision to put on ECMO, the decision to prone, inhaled epoprostenol is another thing that we're using a fair amount of. It's all basically patient care based, specific patient care based on how they're clinically doing.
Now, we mentioned a little bit earlier that they've kind of closed the schools and things. And have you seen any negative effects from that in the hospital? And I'm asking it from this perspective because obviously when you close all of the schools, you have a lot of frontline staff, pharmacists, nurses, and even physicians who now may not have as much opportunity to be at the hospital, at the bedside, taking care of these patients. Have you seen that, or are there things in place that have helped with that?
Well, and that's where I would say, again, the University of Washington has really stepped up, and they have a whole host of resources. Now, me specifically not having children, just the furry kind, I haven't had to go through these resources thoroughly, but they have a lot of resources for childcare availability for a lot of our frontline providers, and they've made those available.
Now, what have you been doing to try to follow social distancing while working in the hospital? Because there are times, you walk through and you would pay for 6 feet of space around you sometimes. Sometimes it can be really hard.
I think everybody is so focused on it now that you don't have to worry about, everybody kind of waves from a distance. Oh, hey, nice to see you again. I'm wondering if they brought him out of retirement, but one of our respiratory therapists today, I haven't seen him in probably 6 or 7 years, was on the unit today. And I'm like, Ahmed, I haven't seen you in years. And he's just like, waves. I'm like, yep, just keep him busy. So, it's, I think we're all kind of in tune to it. Not having the visitors really helps with that. There's still some times when, obviously I was like kind of eyeballing the CCU team today as they were rounding right outside my unit. And they were all kind of grumped together and like, geez, you guys need to like span out a little bit more. But, I think most of us have kind of taken that to heart.
Now, our knowledge on COVID-19, like you mentioned, is changing by the hour. So, what resources are you using and kind of what are you doing to keep up? Because I don't even have a job right now, and I feel like I'm drowning in COVID-19 information. Yeah,
it comes fast and furious. And, the university's been really good. We have, obviously our external site, but we also have internal sites for a lot of different things too that move a little bit more rapidly. We also have, tracking for positive patients in the hospital, where they are, what their status currently is, and what the trajectory is kind of looking like, using our EMR. And so there's a lot of resources internal that the university, and I think, having kind of the machinery of a big university is a big advantage in this setting. I think the concern I have is some of the smaller programs, smaller hospitals that are out there that don't have access to all this. And I think that's why UW Medicine did a great job in like making everything available. You know, I've certainly been I have former residents all over the country, and you know, they're texting me, can you send me this? Can you send me that? And so we're sharing as much information as humanly possible, I think, at this point. And that's a big thing too, is just being in communication with your peers around the country, because they may not have all the resources you have.
When you try to see the positive side of things, it is in times of crisis where you really see the pharmacy family come together and everyone really help each other out. I think it's been evident with everything that's been happening with all this. And so, I mean, hearing all of that, that's awesome. Really, really speaks, I think, to the character of pharmacists and kind of what we're doing.
Absolutely. I think, you know, I always joke with my residents that pharmacy is a very, very small world. So if you piss somebody off, it's going to get around, right? And so, but it is a small world on the good side too, in that we all care for each other. And I think we all have a respect for our jobs and what we do and want to help each other succeed.
So it sounds like, though, kind of going back to the resources, it sounds like, you know, are you trying to keep up with the articles or things as they published, or are you kind of stepping back and really just utilizing kind of the expert guidance from like UW and like the ID team and things like that?
I do both. I certainly review our internal stuff, our internal guidance, and what they're promoting. But you know, PubMed right now, their front page, you can access pretty much everything that's coming out about this. Right on the front page. And so I always eyeball that every day, like, see, is there something new that may be of interest to me to review? A lot of it's all so early that you know, it's not necessarily great science at this point, but still some interesting ideas that are coming out. You know, I've heard some people talking about the mechanism of action, or mechanism of entry of the virus is using the ACE2 receptor, and some people talk about using Giapreza, or are patients on ACE or ARBs at higher risk. You know, some of these kind of pharmacy specific questions are certainly interesting, but don't have anywhere near the level of data to really comment on it.
Now, just as I reached out to you when all of this was happening, I imagine that you are the point person for a large amount of people who have questions about COVID-19. So I'm going to call this we'll call this the family and friends segment. Is there any common misconceptions or questions that you would like to either kind of address in this setting?
Well, I'd really like to encourage my dad, who's 80 and has some health conditions, to stay the hell home. My half sister was telling me he was out at Home Depot the other day, and I'm like, I don't know. I would just, that's what I've really been stressing to my family and my friends, is stay home. Just stay home. Avoid other people as much as you can. Flatten the curve. You know, I think most people are familiar with that phrase now. And try to keep your social distancing, even if you do have to go out. Wash your hands a lot. And so just kind of the common sense things, because we don't know how bad this is going to get yet. Mm-hmm. It hasn't really, I mean, it looks like New York's getting slammed a lot harder than we are right now. And that may be due to the fact that, you know, it's a much more population dense area, maybe different demographics and things like that. But they're getting really slammed. And you look at what happened in Italy, and they're absolutely slammed. And so it looks like Spain's getting in trouble too. And so I think, as long as we can, and I try to stress that with my family and friends as much, and like through social media, to maybe my friends who aren't as savvy in the medical world, you know, hey, this is really important. You really need to listen to them when they tell you to do this.
And I think something that may be frustrating with it is, if the social distancing actually works, right, we're going to feel like there are going to be some people who treat it as, look, nothing happened. Why did we stay in? Where it's like, that is a result of the social distancing that we did. So there's not going to be an immediate kind of benefit from this. And you mentioned your dad. I think the older generation, ironically, is having a harder time with the social distancing than the younger one. That's what I've, through my family and friends, that's kind of what I've gathered as well.
Yeah, no, I would agree with that. I think I'm a Gen Xer. We were raised to be socially distant, and I think the millennials, they operate online pretty much, right? So I think they're probably more comfortable with it. I would say though that it's still maybe the older population needs that social contact at some point, and so I would say reach out to your family and and just call them and see how they're doing, and just make some contact that way. And if they need any help, you can arrange to get help for them. I would certainly encourage that kind of social contact.
So as we're kind of wrapping up here, if you had to, re-emphasize any specific points that you've kind of mentioned throughout when thinking about either preparing for, kind of caring for these patients, what would be some of the highlights that you would have people really try to remember from this podcast?
And again, this changes somewhat, hourly, if not daily. But the big thing for us as pharmacists to remember, look at our PPE uses. Are there any other ways to limit it? We use glove boxes in our ICU satellite. Do we really need to have our technicians, double gloved and masked and, all of that? Look at specific medications that may run low. I don't think we have the full story on a lot of these, but, when I first started seeing some of these reports, I told our purchasing guys, stock up on some hydroxychloroquine because I think this might be something, and stock up on some tocilizumab. I haven't seen personally any use of it yet, but I told them that those may be things that are coming. And so just trying to stay ahead of it as best you can is going to be the most important thing. Look at ways in the hospital to limit the number of people that are there if you can. Telework if possible. Most of our IT department is all teleworking from home now. Our refill authorization center, which is all run by pharmacists, is doing most of their stuff by telework. And so I would say limiting contact with other people, conserving your PPEs, and keeping an eye on the literature to see what may be coming.
Well, let's end on a little bit of a lighter note. I think at this point, most of us, hopefully, are hand washing experts. So when you're doing the 20-second scrub, do you find yourself humming or singing any songs in your head?
It's funny. I was doing the happy birthday thing for a while, but I got really sick of it. So I just started counting down. I do a 10-second countdown and then another 10-second countdown because I'm like, I know like I've seen some people saying that there are playlists out there. I'd like to see some of the good ones. Do you have any that are your favorites?
I got a couple here. I got a couple options here too. We have some oldies, some new stuff. So the chorus from "Take Me Home, Country Roads" by John Denver. That is 22 seconds.
Okay.
"Africa" by Toto. That chorus.
I love that song.
22 seconds. That's exactly right. That first verse from "Ain't No Mountain High Enough" by Marvin Gaye, that is 24 seconds. And then the last one for the young guns listening, it is "Truth Hurts" by Lizzo. That chorus is 23 seconds. So a little longer than 20 seconds, but we're pharmacists. I think a lot of us are we overachieve in a sense. So I figured a couple extra scrubs wouldn't hurt.
No, my hands are pretty torched already today. So.
Well, Andrew, I really appreciate you taking the time to come on here. I can't imagine how busy and how chaotic everything is. So we really, really appreciate it. I think there's going to be a lot of people who listen, both in the healthcare field and maybe not in healthcare, who hopefully take some of these messages to heart. So I really appreciate it.
Absolutely, Nick. I really appreciate talking to you.
All right. Thanks again.
Bye.
I've been working with Andrew over the past 2 to 3 weeks to try and come on, and that was great, even better than I anticipated. I was hoping for our conversation to be more focused on a personal perspective of what it's like being in one of the cities that is a hotspot for COVID-19. What changes he's had to make, what his hospital and health system have been doing. And hopefully for some areas that haven't seen this or things, you may be able to get some ideas from our discussion as to things you can do and implement to help, make yourself, the other pharmacy staff, all those things as safe as possible. Since our initial discussions, other places have had cases shoot up, most notably New York State. Things are changing around COVID-19 every day, if not every hour. So once we have some definitive data, some well-designed clinical trials, I'll certainly have someone on to do more of a deep dive into treatment, discussing the literature and things like that. But it just seemed premature at this point because in a week, everything we know about the treatment could change. And it's a little less likely, but I wanted it to be more of a narrative type of episode, and that's why the flow is kind of the way it is. Now, I read and I continue to read stories where everyone is emphasizing to support your local independent businesses and restaurants in your cities, and I'd like to echo that message. Take out gift cards, merchandise, whatever you can do, I know will be greatly appreciated for all of our favorite independent businesses. Your favorite local coffee shop, your little brunch place, your corner nook, the place you go to get a cocktail, all those things, they're hurting. And so if you can, definitely continue to try to support them. But don't forget about your local newspaper, journalists, writers, magazines. Times like these need really good independent reporting and writing. And as this continues and even afterwards, we'll certainly continue needing them. So strongest recommendation to please get a new subscription. Everyone's going to have a little more time on their hands. Let's read a little bit more. I also want to highlight some newspapers or magazines that have their COVID-19 content available for free. Well, at least the most important stories available for free to all readers. So be sure to bookmark these sites: the Washington Post, the New York Times, the Atlantic, and the New Yorker. Those are the four that stand out to me as creating really good content. Their stories have been incredibly eye-opening and helpful as we understand how to deal with our new life in this pandemic environment. Now, a quick reminder that we have our listeners bracket still accepting votes. Remember, we want to try to crown the best medication in critical care. So if you want to vote, it's the listeners bracket. We want the listeners to have a voice, and things are heating up here. The Sweet 16 into the finals there's going to be a lot of competitive and very 50-50 matchups. So go to our Twitter page. It's at PharmacyToDose, TO2Dose. And we also have released a 3-part episode where we have 4 amazing bracketologists, and they are Matt Robertus, Josiah Smith, Brian Gilbert, Melanie Smith, and they were an absolute blast to do all of that with. And they're dissecting the 4 regions and ultimately picking their winner of the critical care medication March Madness bracket. And so, like I've said, if you need a little levity, you want to have a little bit of humor, you want to try to relive sports, I'm at the point where I'm watching YouTube channels, or YouTube games. So, I have a need. I'm sure there's others there. But we'll get back to our bi-weekly on Wednesday release schedule here soon. I thought that this episode was too important to wait to release. So we'll get back to a normal release schedule soon. And I know everyone's going to have a little more free time on their hands. So if you have any requests for episodes, guests, or content, let me know. And then likewise, obviously, if you have any feedback, either positive or negative, please always reach out. Either, PharmacyToDose on social media or PharmacyToDose@gmail.com if you want to shoot me an email. And I said it in the episode, but I want to say it again. It's times like these where we're able to see how strong the pharmacy family is, the critical care family. From the interactions I've seen on various listservs, social media, even email, it's as strong as ever. We're going to get through this together. Love you guys. And I'm going to keep working on creating a reference list for some of this COVID-19 content. I'm still figuring out the best way to do that, since all of this is really a living, breathing document, right? Everything's changing by the moment, but should have something by the end of this week. So thanks for listening. Thanks for your support. And until next time, I'm Nick Peters, and this is Pharmacy to Dose, the Critical Care Podcast.